obstetric considerations. So the case for today, we'll be looking at a 28-year-old pregnant woman that presents with fatigue and shortness of breath. Okay, so we'll scroll down and see what are our practice objectives, what we are supposed to learn. So, this is the practice objective. At the end of this session, we should be able to adapt these changes to our practice. We're supposed to be able to list the physiologic changes that occur with pregnancy, and also to be able to describe how these physiologic changes affect maternal well-being, and also how the physiologic changes of pregnancy affect the disease presentation. We should be able to describe changes in arterial blood gases that occur during pregnancy, and list the goals of oxygen therapy in pregnant women, recognize and describe signs of maternal distress, and to be able to recognize and describe signs and fetal distress. We should also, at the end of this session, to be able to list the multidisciplinary team members that is required for optimal care of a critically ill pregnant patient, and also describe the unique considerations during resuscitation of pregnant women. We should also know how to utilize the cognitive aids for obstetric emergencies and be able to access COVID protocols for obstetric patients. We are in a COVID era. So let's start. This is the case. A 28-year-old pregnant woman with a gestational age of 29 weeks presents with fatigue, shortness of breath. Her symptoms started 2 days ago with a stuffy nose, rhinorrhea, that is catarrh, and feeling of fever, although she has not checked her own temperature. Her pregnancy has been uncomplicated up to this point, but now she is concerned that she does not feel much fetal movement for the last day. She's a teacher and she's not aware of any exposure to SARS-CoV-2, that is COVID-19, but she does interact with children daily. So her obstetric history reveals that she has 2 previous uncomplicated term deliveries, and her past medical history reveals that she has hypothyroidism. That is, the thyroid function, the thyroid gland is not, is hypoactive. There was nothing in the past surgical history. Social history reveals that she lives at home with her mother, her 2 children, and her husband. She is on levothyroxine. She has hypothyroidism, so she is on supplement, levothyroxine. There was no non-allergies. So in this segment, the specific practice change objectives that we aspire to change in our practice wherever we are is to be able to list the physiologic changes that occur with pregnancy, and to describe how physiologic changes of pregnancy affect maternal well-being, and to be able to describe how physiologic changes of pregnancy affect disease presentation, and to be able to describe the changes in arterial blood gases that occur during pregnancy. So with this segment, if Dr. Hassan Ali Mena is with us, he should take us through the first 3 questions here with the participants. Dr. Hassan?
Yes, good evening, sir. Good evening, everybody. So I want to take the first question, which says, each of the following are normal physiological changes for pregnant patients' cardiovascular system, except A, increased cardiac output due to increased heart rate and stroke volume, B, dilutional anemia from increased plasma volume. C, supine hypotension syndrome. D, autocaval compression by the gravid uterus. And E, increased blood pressure due to high systemic vascular resistance. So we should type the answer in the chat box. Let's make an attempt to type the answer in the chat box. Okay, answers are coming in. E. Another person also typed E. Okay, a few more seconds more. Okay, we have only 2 attempts. Okay, another E. Yes. Okay, so the answer is E, like everybody is typing. So it said each of the following are normal physiological changes for pregnant patients' cardiovascular system, except. Now, if we take A, it says there's an increased cardiac output due to increased heart rate and stroke volume. Yes, there's an increased heart rate and there's an increased stroke volume. We all know what stroke volume is, the volume pumped by the one side of the heart per heartbeat. So the combination of this would cause an increase in cardiac output, which is true. Now B, there's dilutional anemia from increased plasma volume. Yes, this is true too, because there's increased plasma volume, even though there is increase in red cell mass, but the increase in plasma volume is more, so there will be dilutional anemia. C, there is supine hypotension syndrome. Yes, this is a syndrome that happens in pregnant patients that are past 20 weeks. The uterus compresses the inferior vena cava and reduces venous return. So there's hypotension in the patients, which is true. D, autocaval compression by the gravid uterus, which is the pathophysiology is just like that in C. And E, increased blood pressure due to high systemic vascular resistance, which is false. The blood pressure actually reduces for the first and second, and then tries to rise by the 3rd trimester. Now we go to the second question. The second question says, each of the following are normal physiological changes for pregnant patients' respiratory system, except A is decreased oxygen consumption, B, increased tidal volume and respiratory rates, C, respiratory alkalosis, D, decreased functional residual capacity, E, rapid desaturation during periods of apnea. So we have 30 seconds to type in our answers. Okay, A. Another person says C. More answers? Okay, a few seconds more. Okay, so we have A. Okay, one person with C, 3 people with A. Okay, so the answer is A. The question says each of the following are normal physiological changes for pregnant patients' respiratory system, except decreased oxygen consumption. There's actually an increased oxygen consumption because of the high demand by the mother and the fetus demand for oxygen. These 2 factors increase the oxygen demand. B, increased tidal volume and respiratory rate. Yes, there's an increase in tidal volume and there's an increase in respiratory rate in pregnant patients, and that is why they appear dyspneic. C, respiratory alkalosis. Of course, if there's an increase in respiratory rate, there is the patient loses carbon dioxide, and therefore there is respiratory alkalosis. D, decreased functional residual capacity. Functional residual capacity is the amount of air that's left in the lungs after expiration, after normal expiration. So, and this is reduced in pregnant patients because of the gravity thrust, which pushes up the diaphragm. Now, and E, there's rapid desaturation during periods of apnea. Yes, there is rapid desaturation because of the high oxygen consumption and then the decreased functional residual capacity, which is usually our oxygen store. Okay.
Yes, if I may come in,
yes, sir.
Just brief. There is, I think there is a reference where you'll be able to get all these changes in pregnancy.
Yes, yes. When you press the question
for revision, I think. So you'll be able to get all this thing to be able to revise. Thank you.
Yeah. Thank you, sir. So all these changes we mentioned will be found in that resource that he just pointed out. So the next, it has been pasted on the chat platform. So the next question is true or false? Dyspnea is common during pregnancy, occurring in 60 to 70% of healthy pregnant women. So is it true or false? Let's see the answers in the next 30 to 45 seconds. Dyspnea is common during pregnancy, occurring in 60 to 70% of healthy pregnant women.
This one is false, no? It's false.
Please chat it, write it in the chat box. Okay, we have false, we have true, we have true, we have another false. Okay, okay, so we have a few answers. 50% said true and 50 said false. Okay, when you go through the resource setting, the resource that will be sent, you will see that dyspnea, like I mentioned earlier, there is increase in respiratory rate, increase in tidal volume because of the oxygen consumption that is increased. So dyspnea is common during pregnancy, occurring in 60 to 70% of patients. It is true. This happens in most pregnant women. So there is dyspnea in 60 to 70% of patients. We'll find that in the resource that was just pointed out. So the next question is: pregnant patients have an increase in their tidal volumes and respiratory rates through normal physiological changes of pregnancy. What changes would you expect to see on arterial blood gases? Any attempts? What are the changes we would expect on arterial blood gases in pregnant women? Respiratory alkalosis. Respiratory alkalosis. Okay, we're getting respiratory alkalosis as an answer. Okay, so we're going to show the resource. It's still part of that resource. You see that for the arterial blood gases, since there's an increase in tidal volume, an increase in respiratory rate, and like I said, there is a loss of carbon dioxide. So the partial pressure of carbon dioxide in the body, in the blood, is reduced. So there's low carbon dioxide tension, and that is the respiratory alkalosis. So when you check the PaCO2, is going to be slightly low, and then the pH is going to be slightly high. That's towards alkalosis too. And then the PaO2, the oxygen saturation, is within the normal range. because the oxygen saturation is going to be within normal. The patient breathes in because of the increase in tidal volume and the respiratory rate. There is more oxygen intake into the blood, so the oxygen tension is within the normal range, but the PaCO2 is going to decrease. I think. Okay. List some obstetric causes for dyspnea and acute respiratory failure. Can we list some of the causes, obstetric causes for dyspnea? Obstetric causes of dyspnea. Any attempt? Obstetric causes for dyspnea. Okay. Okay. Large for dead uterus, acid aspirations, increased oxygen consumption. Okay. Multiple gestation. Okay. So we have 4 attempts. Postural hypotension. Yes. Okay. So we have a resource below the question. Anemia from severe hemorrhage, hypertensive disorders. Yes. Okay. Let's look at the resource. Okay.
No, I think we go back to the main
Yes.
presentation.
The main, yes. Just below the question.
Below.
Yes. So we can see by various systems, the causes of dyspnea in obstetric patients have been listed. From the head, eyes, ears, neck, and throat, we have angioedema, anaphylaxis, pharyngeal infections, deep neck infections, foreign body. So we have causes from the chest wall, rib fractures, pleural chest. Pulmonary, you have things like COPD, asthma, pleural effusion. Cardiac causes of dyspnea in obstetric patients, acute coronary disease, heart failure, cardiac tamponade. Neurologic, things like stroke and even neuromuscular diseases can also happen in pregnant patients. Toxic or metabolic, we have organophosphate poisoning, all those poisonings. Anemia can also cause it, sepsis, and then miscellaneous causes. Hyperventilation, anxiety, obesity, and ascites. All these are causes of dyspnea in pregnant women. Factors that can cause dyspnea in non-pregnant women can also cause dyspnea in pregnant women. Thank you very much.
Yeah, thank you very much, Hassan. If I may recap a few points there, if you go back to that chart a bit, well, now these are causes of dyspnea in any patient, but which can happen to both pregnant and non-pregnant patients. But here under miscellaneous, you can see that pregnancy has been highlighted in yellow, that on itself, pregnancy as a condition, physiologic condition, can cause dyspnea. This is the emphasis. Okay, let's go to the case update. Now, the patient is found to be having contractions. You remember 29 weeks gestation, but they are irregular and occur approximately every 8 to 12 minutes. Her cervix is closed on examination. And these are the maternal vital signs: temperature 38.9 degrees Celsius, heart rate of 115 beats per minute, blood pressure of 140/75 millimeters of mercury, and respiratory rate of 18 per minute, and the saturation the pulse oximetry revealed, recorded 91% room air. And the fetal monitoring showed that the fetal heart rate is at 125 beats per minute. So what we're supposed to learn here is to be able to list the goals of oxygen therapy in pregnant women, to be able to recognize and describe signs of maternal distress, and also to be able to recognize and describe signs of fetal distress. This is what we do every day in our various facilities. Now, why the goals of oxygen therapy is important here, you've seen that saturation is 91%. So let me call on Dr. Salim, if he's around with us, to take us through this couple of questions to be able to illustrate this. Dr. Salim?
Yes, I'm around. Okay. Good afternoon, everybody. So based from the case update, it's obvious that the SpO2 of the woman is 91% on room air. So now we have an interactive question, which says, according to the Society for Maternal Fetal Medicine, a group of high-risk pregnant experts, what is the goal SpO2 for pregnant patients? So we have 30 seconds to respond on the chat box, because it's only when we identified whether the patient has reached the goal SpO2 that we can determine the next line of management. So what do you think is the goal SpO2 for pregnant patients based on the Society for Maternal Fetal Medicine? Okay, the answers are coming. Okay. Someone says greater than 90, another one minimum of 95%. Okay, not less than 95%. Okay, 95%. Minimum of 93. Okay, somebody said greater than 94%. Okay, thank you for the answers. Yes, based on there is a resource material attached with this, which based on it, the goal SpO2 for pregnant patient is greater than or equal to 94%. So we have the material, we can later go through it, but based on this, the goal SpO2 for pregnant women is 94%, greater than or equal to 94%, as against 92% in the non-pregnant state. So from the update, the patient SpO2 is 91, so meaning she has not reached the goal. Then there is a need for oxygen supplementation. So oxygen, like any other drug, there has to be indication for it. And then, so now we have identified the indication for oxygen, but then we have to prescribe it in terms of the dose, which is the flow rate, and then the route of delivery. So the next thing now is to determine the appropriate means of delivering oxygen to the patient. So there comes another interactive question. Which of the following oxygen delivery devices can be used in pregnant patients? A is Venturi Max. B is Max with reservoir bag, no rebreather. C, nasal prongs. D, high flow nasal cannula. E, all of the above. So which of these can be used for pregnant patients? We have 30 seconds to respond on the chat box. D, high flow nasal cannula. Okay. D, E, nasal prongs, all of the above. All of the above, all of the above. So in majority went for all of the above. Yes, you can use all of the above to administer oxygen for the patient. From our previous sessions, in one of our previous sessions, we have discussed about oxygen delivery devices. And then depending on the center which we practice, we may not have all these devices, but there is a particular one that is available to all of us, which is nasal prong. So depending on what you have, you can use all this can be used for the patient. And you know, from our previous sessions, we have already identified when to use which device. So depending on the oxygen requirement, that will determine the type of device to be used. So, but by and large, all these devices can be used for the pregnant woman. Thank you.
Yes, thank you, Dr. Salim. And I actually like your emphasis on telling the participant to refer to the previous sessions on these devices. And I want to also remind them that we may not have everything in all our facilities. So everything, the practice is that you check every morning the resources that you have, okay? And then how you, with the fact that you have all this, then you need to titrate, you need to use the appropriate device so that when you want to escalate the therapy to achieve the goal you set for yourself. Thank you very much, Dr. Salim. Now, we have a case update. The patient is placed on oxygen by nasal cannula at 4 liters per minute. Initially, her SpO2 improves to 92 to 93%. So not yet approaching the goal we set as for ourselves. But an hour later, she requires 10 liters per minute by non-rebreather mask to maintain an SpO2 of 95%. The health facility to which have a neonatal care unit or staff to take care for a preterm baby, nor does it have an adult ICU. The decision is made to transfer her to a center with the appropriate multidisciplinary team. So there are things we need to know on this. Let me call Dr. Irene to help us with this section. And there is a question. Dr. Irene, if you are with us.
Yes, I am. Good afternoon.
Thank you.
So the question we have is, in one systematic review, 75% of pregnant patients who contracted COVID-19 were asymptomatic. What are considered danger signs for a pregnant woman that should prompt her to present for clinical care? So if you can put some of that in the chat box. If we feel she has COVID-19 also, what are the danger signs? Okay, we have dyspnea, danger signs, either due to the COVID and if she's pregnant also in pregnancy, that would cause her to present urgent care. Breathlessness, it's true. Difficulty in breathing with low SpO2, reduced fetal movements, got dyspnea and breathlessness. Okay, while more answers will come in, just hypoxemia, fever, breathlessness. So we know with COVID-19, we have danger signs. You know, if patient is becoming dyspneic, difficulty in breathing, gasping for air, reduced level of mentation or consciousness, chest pain, inability to eat or drink, coughing up blood, distressing cough, all of that. Then for a pregnant woman, in addition, if she's ruptured membranes, if she's complained of reduced fetal movement, severe headache, convulsion, persistent fever, unexplained abdominal pain. And we have all of that in a resource. I don't know if we can have that. So we've had a lot of dyspnea and low oxygen saturation. There's a resource material that there's a 19 danger signs, which applies to all patients. Then in the obstetrics, things that should warrant her seeking clinical care and would make her come. I'm sure the obstetricians in our beast will understand. Of course, when a woman is in labor pain, she will come to the hospital, amongst other things. So I think we can move on. So we've got a lot of our responses were on this now, which is good, but we should also remember there's also an obstetric component to these patients. So fetal distress is a very broad term, and it's difficult to give precise clinical definitions, but it shows that the baby is in danger and becoming hypoxic. Immediate delivery has to be considered because neurological damage may occur when the fetal brain is deprived of oxygen. Usually there's some form of antepartum fetal testing to assess hypoxia in high-risk pregnancies. And monitoring during labor also is key in providing information on the status of the fetus prior to birth. Now, our next question is, what are the options? Remember, this woman also complained of reduced fetal movement, in addition to all the issues she has now. What are the options to monitor fetal well-being? Can we please put in our chat box? Options in monitoring fetal well-being. We have CTG. Yes, cardiotopography, yes. Cardiotopography, yes. Yes, CTG. More responses. We have ultrasound, ultrasound scan. Okay, fetal thick charts, Doppler like CTG, or physical profile. Thank you. Ultrasound, tourniquet, fetoscope, fetal blood sampling, CTG. Thank you. So while we keep the answers coming, there's a resource center there that gives a tutorial. There's a tutorial there on fetal heart rate monitoring, which has some questions before, but we won't really dwell on that. And things on CTG. So CTG is cardiotocography, and it records the fetal heart rate, either from a transducer placed on the woman's abdomen or an electrode put on the fetal scalp. Usually the fetal scalp is if you feel the patient is a bit obese and you really cannot access it from the abdomen, so fetal scalp. But I think in a lot of our centers, our transducers are placed on the woman's abdomen to record that, and it's usually continuous or intermittent. However, for some patients, like if we look through the options here where you do continuous CTG, the patient has meconium stain like for maternal pyrexia, temperature greater than 38, which this patient has. Her temperature is 38.9. Use of oxytocin for labor, fresh bleeding, maternal request, abnormal fetal heart rates, and a woman having regional anesthesia, like labor analgesia. So there are a lot of things which this our patient ties into. She's hypoxic, she's pyrexic, she has complained about reduced fetal movement, so she would need continuous CTG. I hope we all agree with that. Now with the, so we have, so I just wanted to check. So our options, like I say, so we have the CTG, abdominal fetal, we have fetal blood sampling, the physical profile. I guess we'll get back to that, but from this resource, you can get so much about what the characteristics of the CTG is. Dr. Datti, should I go back or we can continue? I'm looking at time.
Yeah, I think we should go back to the main presentation.
Okay.
Yeah.
Okay. So the next question is, which one of the following is a reassuring sign of fetal well-being? Which one of the following is a reassuring sign of fetal well-being? A, late deceleration of fetal heart rate, loss of baseline variability in fetal heart rate, Pascal pH less than 7.2, baseline fetal heart rate between 110 to 160 beats per minute. We have some answers in the chat box. We have the baseline fetal heart rate between 110 to 160. Okay. Sorry, there's no E option, it's A, B, C, D. Thank you. So a lot of us have said baseline fetal heart rate between 110 and 160 beats per minute. And that's true. I would just like to take us back to the resource setting and say, now to get an abnormal, the characteristics of the CTG, and when we see the abnormal features, when your baseline fetal heart rate is less than 110 and greater than 160. The baseline variability of less than 5 beats, that means between your two recordings of fetal heart rate, when you have reduced or absent accelerations and presence of decelerations. Now, the important thing is fetal heart rate variability. It refers to the normal beat-to-beat changes in fetal heart rate. The normal variability between 5 to 15 beats, and it can be measured by analyzing 1 minute portion of the CTG. Now, with this CTG we have now, it shows you on the top part, it shows it shows the fetal heart rate, and at the bottom it shows the uterine contraction. Now, with a normal, you have some variability, which a contraction, you have an acceleration, but you should come back to normal. And when you have a change, a variability of outside less than 5 or greater than 15, then there's the problem. If it's greater than 15 is increased, less than 5 is decreased, absent of 2. So this may show features of fetal hypoxia, prematurity, or when we give parent opioids. This will affect the fetal heart rate variability. Now, what are accelerations? They are periodic transient. If you can move down to accelerations, periodic transient increases in fetal heart rate. So it's defined as a fetal heart rate greater than 15 beats per minute for more than 15 seconds, an increase. So if you had 120, you got it to 135, 140, more than 15 seconds, that's an acceleration. And it shows is reactive, and they're usually associated with fetal activity, and it shows that the fetus is healthy. And you get that with usually with uterine contractions. Now, decelerations are also periodic, and they should be transient, actually with uterine contractions, and there are 4 types. I'll just go through this. I know it's a long CTG, is a different kettle of fish, but we realize that accelerations are good, they are okay, they are transient. Decelerations could be early, late, variable, and prolonged, and I think that's where there's really a worry. but they are tied also with uterine contraction. So an early deceleration occurs with each contraction and it should be uniform. And if it's early, it's like a mirror image of that uterine contraction at the onset of uterine contraction. But the thing is that the fetal heart rate should not fall more than 40 beats per minute. And that is usually actually with the head, during the contraction, compression of the head. And usually putting the woman in the supine position and changing helps. This is not actually with poor fetal outcome. Late decelerations are also due to uterine contraction, prolonged and variable. All these ones are actually signs that there might be some hypoxia, there might be some cord prolapse or maternal hypotension. I think it would be nice during our study time later to take a look at this resource, because this is a long CTG interpretation and managing patients is quite long, and I think it's not what we should do in a hurry.
Yes, thank you very much, Irene, for your insight into that. Let me wrap up this section by emphasizing that you have what this section is trying to tell us, that no matter our settings, no matter poor resource we are, we have fetal clip and the fetoscope that we can record the fetal heart rate that we can rely on. We are aware that some centers may not have the luxury of having this equipment. Sometimes you have it and then they are bad and so on. So the practice will be the same. If you are richly resourced, then you can also make use of the other parameters. And that was a very great resource for everybody to rely on that tutorial. Thank you very much.
Professor, just to add some in the option, sorry. We have an option C for fetal scalp pH, for those who have resources. The fetal scalp pH should be more than or equal to 7.25. So when you have that less than that, it means the fetus is becoming acidotic, and of course it's not reassuring. That was just to add for those who have that. Thank you.
Yeah, thank you. Thank you very much. So again, you can see the reassurance sign there is a heart rate, which we can count with our fetoscope. We don't need a sophisticated equipment. Thank you very much once again, Irene. So here, we need to also look at what is the role of our multidisciplinary team members required, in the management of this case. So can I call on Dr. Embu? You've been waiting patiently. Take us through this section and see what we need to learn on this practice change objectives in terms of multidisciplinary team.
Okay, thank you, Dr. Datti. Greetings to the co-panelists and the participants and everybody involved in this section. All right, so we're talking about multidisciplinary team members. And there's a question which says, list the multidisciplinary team members required for optimal care of a critically ill pregnant patient. And just as the tradition, you can just type your answers on the chat box. In the next maybe 30, 40 seconds, just list the members of the team, multidisciplinary team members required for optimal care of a critically ill pregnant patient. Okay, we're still expecting responses. Okay, responses have started coming in. Anesthetist, neonatal, pediatrician, obstetrician, anesthetists, intensivists, neonatal, gynecologists, anesthetists, okay, obstetrician, neonatal intensivists, midwife, physician, okay. All right, thank you for the responses so far. There's a whole team. I think we have a resource that we could click and see. Here, this resource is talking about levels of maternal care. And if you go down, we have down to the table. Can we scroll down? Yeah, it's talking about what, can we still scroll down? There's a table down. Yes, this table is talking about talking about different levels of maternal care. We have levels 1, 2, 3, and I think it can actually correspond to our primary, secondary, tertiary care in our setting here. So we also have on this table, we have healthcare providers. So for level 1, we talk about family physicians, midwives, and so even in our own centers, we can also at that level make do with medical officers. At that level, we can make do with medical officers, and then the nursing care, of course, and the anesthesia providers. At level 2, apart from maybe family physicians, an obstetrician should be there. And especially if a family physician, you should be skilled in taking and conducting cesarean sections. Then we have midwives, of course, and obstetricians and this anesthesiologists at this level, and other things, team members like a general surgeon may come in at this level too. And then at the level 3, we could have the obstetrician, of course, the neonatologist, the midwives, the neonatal nurses, the intensive care nurses, and obstetric anesthetists, anesthesiologists, and and perinatologists, and so on. And of course, other specialties like general surgeons, neurosurgery, cardiac surgeons, and so on and so forth. So the list increases as the levels increases. So this resource is very, very rich. You can also make use of it. You can go through it later on. Can we go back to the presentation? Thank you. All right, so the next question after that is saying, what monitors should be placed on this patient? What monitors should be placed on this patient? Okay. Can we still take a few minutes to type this on the chat box. Monitors. Okay. Okay. No, I'm still no responses coming, but we still have another resource there, I believe. So, okay, pulse oximetry, ECG, blood pressure, pulse rate, CO2 coming in, CTG, all right. Okay. So this is a critically ill patient of course, and just as we said, some of your answers, of course, pulse oximetry is very important in this patient. It's very critical, and ECG is very critical. Yes, carbon dioxide monitoring is good to provide ECG, of course. So most of your responses are okay. Blood pressure, whether blood pressure also is very important to monitor. And of course, we can monitor the baby too, as we said, using CTG. And so, so you can still get more on that from the resource. From the resource. Yes, okay. So I believe this Society for Maternal Fetal Medicine, the very, very rich resource. And the link is already, I believe is already there on the chat box. So, all right, can we go back to the presentation? All right.
Okay. All right. Okay. There's a last part of it. Go ahead. I'm
Yes,
sorry for
okay.
interrupting you. So
all right. So there's this last part, which I hope we can just get through it quickly. Say for the patient's transfer, she is placed in an ambulance. She is currently receiving oxygen by non-rebreather mask at 10 liters per minute by an E-cylinder. The pressure on the E-cylinder reaches 2,000 pounds per square inch. How long will the oxygen tank last before it runs out? So it's a little bit of calculations. I hope some of us will be able to do that. And this is so important because it will help us to plan if we know how much oxygen we have and how long it will last. And so that we plan properly for the journey ahead. So, all right, okay, we're already getting.
So Irene is trying to remind us that it's a cylinder that is used for, it's a portable cylinder that you can use to transport patients in ambulances or intra-hospital transfer on trolleys or inter-hospital transfer. So the idea here is to be able to calculate, there's a resource, I'm sure, that you should be able to calculate how much or how long will this last you at this high flow. Remember, I said non-rebreather.
Yes, okay. Very good.
Exactly.
It's the resource.
Mm-hmm.
Okay. Well, if we scroll down this resource, I think there is a formula for calculating. Can we scroll down? Let's see. No. Okay.
If you enter into all these things, sorry, Henry, Irene has already done some calculation under 1 hour, about 56, 57 minutes. When you enter like the total supply of that e-cylinder, then the need and so on, then you'll be able to get how much. So you should know that this patient, you should move this patient quickly under 1 hour to a higher facility.
Yes.
All right, that is what it means to guide us.
Yeah, the calculation will give you around maybe 68 minutes or so, about 1 hour or so.
It's in the chat box there. Irene is trying to help us do the calculation.
Yes.
So these are things you can always do anytime. And then when you get used to it, you have this results to refer to it every day. So when you want to transfer, you can quickly within minutes to calculate this, and then you know what you have. All right. Yeah, thank you very much. Yeah.
All right.
So
thank you.
Get back to the main thing. Now, before that, again, I want to emphasize that that great resource where you have levels 1 to 4 of maternal care, which fits into most of our facilities, whether primary healthcare, secondary healthcare, and then tertiary, where you have the teaching hospital, specialist hospital. So the idea is that if you have not done it now, you should be able to now recognize and respect all the multidisciplinary team members, obstetricians, anesthetists, midwives, hematologists, and so on. Recognize what you have and begin to implement to see the objectives of that level. Are you able to meet that? What do you need to be able to function as level 1 or level 2 effectively? Okay, so let's move to the case update to see. Now, unfortunately, the patient status has worsened during transport to the hospital. She continues to contract intermittently and her cervix remains closed. Upon arrival, her status is as follows. Maternal vital signs, temperature has gone up 39.1 degrees Celsius. Heart rate 125 beats per minute. Blood pressure 105/60 with a mean arterial pressure of 75. Respiration has increased from 18 to 24. SpO2 90% on 10 liters per minute by mask with reservoir bag. That's the non-reservoir bag. And you know, we are doing fetal and maternal when being monitoring them. So the fetal monitoring revealed the heart rate is 105 beats per minute with a variable decelerations, which Irene was trying to explain to us, and there's the minimal variability. So if Dr. Suleiman is around, there is a practice, there are 3 practice change objectives here to be able to describe unique considerations during resuscitation of pregnant women and utilize cognitive aids for obstetric emergencies and be able to assess COVID protocols, to be able to have these protocols for obstetric patients, which we can apply. So if Dr. Suleiman is around, he take us through this section to see what should we do to improve our practice.
Okay, sir. Thank you very much, Dr. Datti. The first item there is they're asking us to list at least 1 unique intervention used during maternal resuscitation. So as agreed, we'll give about 30 seconds for people to respond to that. Okay. At least one unique intervention during maternal resuscitation. I'm not seeing, I hope my internet connection is stable because I'm not seeing any response. Hello?
Maybe it's your network, but they can help you put it on.
Am I being heard?
Yes, we can hear you.
I think the
Okay,
responses are coming already.
Okay,
IV
thank you.
fluids, oxygen,
Okay,
capnometer.
yes, I think IV fluid, oxygen therapy, left lateral position, capnometer, okay, IV fluid. Well, they are talking about, something unique, intervention. Well, I think all these are required, but one major unique thing that I see there is the left lateral, the lateral tilt, which is required when resuscitating a pregnant woman. Okay, and I think earlier on we have listed some of the equipment that are used in order to provide this resuscitation. So, like I said, the main thing there is the lateral tilt, and then manual displacement of the uterus, which we all know helps in preventing the autocaval compression syndrome, which will further prevent cardiac refill and also affect our cardiac output, and thereby affecting all the other resuscitative measures that we take. That's the resource center where you see a detailed explanation of that procedure. So let's move down.
Suleiman, stay around. Let's see the update now.
Okay, sir.
Upon arrival to the hospital, the patient is found with continued contractions. Her cervix remains closed. She has now become more somnolent, that she sleeps, she's drowsy, not easily arousable, and it's difficult to arouse. The following information is obtained on arrival to the higher hospital where she was referred. They did the arterial blood gas, which showed a pH of 7.34 and PCO2 40 millimeters of mercury, PaO2 of 100 millimeters of mercury at 10 liters per minute of oxygen, and bicarbonate was 20 millimoles per liter. And the full blood count shows 20,000, hemoglobin 9 grams per deciliter, and platelets 95,000. It's a C-reactive protein that is elevated. And then they did the AST and ALT, that's the liver enzymes that are elevated. And the chest X-ray revealed multifocal bilateral parenchymal opacities. And the fetal assessment, the fetal heart rate, 155 beats per minute. There is a moderate, with moderate variability, and there is a recurrent variable decelerations. So these are the, Suleiman, maybe you now continue from here. We'll see what we can get from this section.
So they want to test our knowledge of the physiological parameters, the ABG, okay, parameters of this patient, whether these values are correct or not. So they're saying we should answer true or false. The following arterial blood gas. It's normal for this patient at this gestational age, pH of 7.37, PCO.
Just look at the results and just say whether it is true or false. They will give the explanation. Just type true or false.
of 40 millimeters of mercury, PaO2 of at 10 liters per minute. And this true or false? Hello? Sorry,
Yeah,
my
the
internet
answers
con-
are
I just
coming.
lost my
They're saying it's true. I've seen true, true.
I lost my internet connection. Let's come back.
We can hear you now.
Okay, sir.
So they are typing true, true.
So we have had about 2 responses. You said it's normal. Okay. We all know some of the changes that occur during pregnancy, especially involving the respiratory system. They tend to have some mild respiratory alkalosis. Okay, but however, in this patient,
Okay, maybe your
so
internet. Okay.
Yeah.
So do we have any resource that we can refer to be able to remind ourselves what is the correct thing here? Yeah. So here we can find what is correct based on the report on this patient. And that's the link. And it is printable, the PDF format, so you can refer to it. If you scroll down, you see where the arterial blood gas is mentioned there, which you can refer to. Okay. So this you can do at your study time as a reference. So if we go back, because I think time is not on our side, yeah. So sorry, Suleiman, we have to move on. Suddenly the patient loses consciousness and she's emergently intubated for hypoxemia and is transferred to the ICU. She has begun to contract regularly every 5 minutes. Her cervix is still closed, but there is a small amount of blood noted on the vaginal introitus. And then the maternal vital signs as follows: temperature 39 degrees Celsius, heart rate has gone up to 120 beats per minute, blood pressure has come down to 95, about 45 millimeters of mercury, and then the saturation now is 95%. Mechanical ventilator settings, mode is pressure controlled ventilation, an FiO2 of 70%, respiratory rate of 20, and measured tidal volume 6 mils per kilogram body weight. And there is a PEEP of 10 centimeters of water that was set, and the plateau pressure reads 35 centimeters of water. The fetal monitoring revealed heart rate of 105 beats per minute, and with a recurrent variable decelerations and minimal variability. So if I call on Dr. Hassan, if Dr. Hassan is still around.
Yes, sir,
Okay.
I'm around, sir.
Yeah, so with this report on the patient, let's see what, let's revise. Let's revise with the participants.
Okay.
These questions and see.
Okay, so there's a question here, but Sorry, sir. The previous question, I saw many people write 2. The answer is false. So you should go back to the resource and go through it.
Yeah, that's why I said we should go to that
Yes.
reference. Yes.
Yes, sir.
Just of, because
So
of
it's
time.
just to notify them. Yes. So the question, can we go down, sir? The question says, if this patient were to go into cardiac arrest, which one of the following modifications is not appropriate during ACLS, that's advanced cardiac life support for pregnant patients? A, tilt the patient 30 degrees to the right during CPR. B, manual left uterine displacement by a provider. C, 2 large bore peripheral IV placed above the level of the diaphragm. And D, CPR with 100 compressions per minute. Okay, so which one is not appropriate? We'll be expecting answers in the next few seconds. There's no time. Which one is not appropriate? Okay. Somebody said A. Somebody said B. Okay, because there's no time, so I'm just going to discuss the answers. So the answer is A, tilt the patient 30 degrees to the right during CPR. We're actually always trying to tilt the uterus towards the left. So when you tilt the patient to the right, you are tilting the uterus towards the right too. And that will compress the inferior vena cava and cause all those syndromes that we mentioned earlier. B, manual left uterine displacement by a provider. We even saw the picture when somebody was trying to displace the uterus with his 2 hands. So it is also appropriate. 2 large bore peripheral IVs placed above the level of the diaphragm. Yes, this is also appropriate. You see it in the resource. And then CPR with 100 compressions per minute. We all know that the CPR is 100 to 120, so 100 is also okay. CPR with 100 compressions per minute is also appropriate. So the answer is A. So in a crisis or clinical emergency, which of the following actions have you observed when providers cannot remember how to manage a certain clinical situation? A, called a colleague for help. B, use the internet or phone or computer. C, gone through a textbook. D, hide or walk away. E, all of the above. So which one have we seen in this when there's an emergency? Which one have you seen? Called a colleague for help, yes. Call a colleague for help. Yes, everybody is typing A. Okay, so that is the commonest and that is the fastest. So we can go down, sir. E, all of the above. Okay. Thank you, sir.
All right, thank you, Dr. Hassan. And then we are being reminded here that there is a manual that you can download on Orthotic Anesthesia Emergency Manual. Is a great resource that you can go through. Every aspect of the care, you can find it there and adapt to your practice, no matter the setting. Okay, let's progress. Let's scroll down. Yeah. So you can download this from this site. Okay. Now, this patient now is diagnosed with acute respiratory distress syndrome, ARDS, from presumed SARS-CoV-2 or COVID-19. She's placed on long protective ventilation settings on the mechanical ventilator, and the maternal fetal medicine specialists are following the clinical status of the patient and fetus. So we want to know what we can do to improve the situation. Dr. Salim, I think there's also a video later on we need to see that. Okay. Hello, Dr. Salim. Dr. Salim? Okay, maybe he has internet issues. Now, what here is a one strategy. What is the one strategy? Quickly, just type maybe 15 seconds. One strategy to improve oxygenation in patients with ARDS. Sorry, is there one strategy to improve oxygenation in patients with ARDS is to place the patient in prone position. Now the question is this possible in pregnant patients? Just type yes or no, and then we proceed. 10 seconds. I want to see a couple of answers at least. More response? Yes. Okay. So let's scroll down. I think there is a video to remind us. We can watch this video once and see.
We will be demonstrating the prone positioning of an intubated pregnant patient. Note there are 5 to 6 assistants, 1 at the head of the bed, 2 on each side, and 1 at the foot of the bed if available. All movements will be made at the direction and count of the respiratory therapist or lead personnel at the head of the bed. This person is responsible for ensuring the security of the ET tube and support of the head and neck. For the proning maneuver, the patient will be turned towards the ventilator. First, a flat sheet will be placed underneath the patient by rolling the patient to one side, placing the sheet underneath so that it may be passed to the other side, and then rolling to the opposite side to complete the placement of the lower sheet. Once the patient is returned to the supine position, monitors including EKG electrodes may be removed. Next, 3 sets of pillows will be placed on the patient. The first 2 pillows are placed on the chest above the gravid abdomen, the second 2 over the pelvic area below the gravid abdomen, and the third set over the lower legs. A second flat sheet will then be placed over the pillows and the patient. The assistants on each side will roll the tissue together the patient, encasing her in the cocoon fashion. The sheets must be rolled tightly to ensure stability of the pillows during turning. Again, all maneuvers will be made at the direction and count of the person at the head of the bed. The next maneuver is to slide the patient away from the ventilator. The patient will then be rolled onto her side by the assistants on the ventilator side pushing under while the assistants on the opposite side push over. The person at the foot of the bed will help guide the feet. Once on her side, the assistants will switch hand position prior to the final prone maneuver. The assistants towards the ventilator will have their hands on top and pull forward and downward, while the assistants on the opposite side pull upward. Once prone, the head should be turned to one side and supported. Monitors can be replaced and the ET checked for security and patency. Pillows may be adjusted as needed. Next, we will check for space between the abdomen and the bed. The arms can be positioned towards the head, down to the side, or one of each in the so-called swimmer's position. The head should be turned and the arms repositioned every 2 hours to avoid skin abrasions and pressure ulcers. All maneuvers can be reversed to return the patient to the supine position.
Yeah, thank you very much. We don't have much time, but you can practice this. Those who have mannequins, this maneuver requires some practice. To simulate before you have a real patient, which you need to do from positioning. Okay, and then you have, now we have been reminded here, you have additional resources for obstetrics and COVID-19. Sorry, what other considerations are required when caring for pregnant patients with COVID-19? I think there is a resource there. So you have additional resources for obstetrics and COVID-19. You have, there is a covidprotocols.org. You have American College of Cardiologists and so on, where you can get all these additional resources, Society for Maternal and Fetal Medicine, and National Institutes of Health. You can get all you need on this, WHO guidelines on maternal health. So in the end, again, we have been reminded of the practice change objectives, no matter where we practice, where you need to know the physiologic changes that occur in pregnancy, how the pregnancy affects disease presentation, to listing the goals of oxygen therapy in pregnant women, and then to recognize and describe signs of maternal distress, very important. Same with fetal distress. And then to be able to recognize and agree that we have a multidisciplinary team, that we all need each other for optimal care of the pregnant patient. And we should be able to describe the unique considerations during resuscitation of pregnant women. We had that we need to displace the gravid uterus to the left, and then to describe the unique consideration utilize the cognitive aids for obstetric emergencies. So I want to thank all the participants, panelists, for participating in this interactive session. This is a session that has been rescheduled for reasons beyond our control, and the next session will be again later this month. Kevin, over to you for closing remarks.
Thank you, Dr. Datti, and also thank you to all the panelists for a great learning session today. And so we are going to close our session with a few announcements. So to wrap up the session, you can visit the Learning Resource Center for the materials that have been presented during this session. There are also many additional resources, quizzes, case exercises, and videos through that link there. Also, the link to the LRC will be shared after the session by email. You can join our community WhatsApp group by scanning the QR code that is seen here, or you can message assist on the number that is written there. So please join us for session 11, which will be held on November 25th. And it's going to be discussing on essential emergency and critical care. And also we are going to share the objectives for the session at least a week before the session. If you have any questions, you can send an email at echo@assistinternational.org. So until then, we thank you all for participating, and we'll see you next month. Thank you. Alvin from Echo India, we can now close this session.
Kevin, so you are the host, so you can just end the session. Thank you. Thank you, everyone.
Okay, thank you, Alvin. Thank you, everyone.